What is OCD and related disorders? OCD is a long-lasting disorder in which a person has uncontrollable, reoccurring thoughts or obsessions and behaviors or compulsions that he or she feels the urge to repeat over and over. Obsessions are reoccurring, intrusive, and unwanted thoughts, urges, or images. Compulsions are repeated behaviors or mental acts that one feels driven to perform because of their obsessions. Individuals attempt to neutralize and suppress these obsessions through their compulsions. These symptoms are often present in tandem with anxiety disorders or other mental health disorders. Symptoms and presentations. Symptoms that relate to obsessions are obsessional jealousy, forbidden or taboo thoughts, thoughts of harming oneself or others, and symmetry obsession. Symptoms and compulsions include counting, repeating words or phrases loudly or silently, repeating unnecessary hand washing, cleaning compulsions, hair pulling, skin picking, nail, lip, or cheek biting, and arranging objects in specific order. Example, arranging objects to be symmetrical. Specific symptoms for related disorders include body dysmorphia disorder, where mirror checking, excessive grooming, skin picking, reassurance seeking, and comparing oneself to others are the common symptoms. Hoarding disorder symptoms include excessive collecting, buying, or stealing of items that are not needed or for which there is no space available. The symptoms of
trichotillomania
are hair pulling, and the symptoms of exfoliation, skin picking. The criteria for OCD is the presence of compulsions or obsessions. Obsessions or compulsions are time-consuming, meaning they take up more than 1 hour per day, or significantly impact social, occupational, or another important area of functioning. Symptoms are not attributed to substance or a different medical condition, and disturbance of these symptoms is not better explained by a different mental health disorder. The prevalence of OCD in the U.S. is 1.2% of the population, or 3 million people have it. 1.8% of female adults have it, and 0.5% of male adults have it, though men are slightly more likely to be affected during childhood.
For our Western theoretical approach, we focused on the cognitive behavioral explanation of OCD, specifically cognitive behavioral therapy, or CBT. CBT explains OCD as a cycle that starts when intrusive thoughts are misinterpreted as dangerous or highly meaningful. These thoughts create anxiety, and the person performs compulsions as a way to reduce that distress. This temporary relief actually reinforces the behavior and makes the symptoms stronger over time. The CBT model fits OCD well because it focuses on how distorted thinking maintains the disorder. CBT helps individuals identify and challenge these disordered thoughts that drive obsessions. Research specifically shows that even though obsessions may look different across cultures, like contamination or religious themes, the underlying cognitive behavioral mechanism is the same throughout. That consistency is why CBT is considered one of the most effective frameworks for understanding OCD. The main CBT treatment for OCD is exposure and response prevention, or ERP. This is considered the gold standard therapy for OCD. ERP gradually exposes the person to feared thoughts or situations while preventing the compulsion behavior. Over time, this breaks the obsession-compulsion cycle and reduces anxiety. The Mayo Clinic specifically emphasizes that ERP is effective across cultures and symptom types, and it directly targets the mechanisms that keep OCD going. Overall, CBT, and specifically ERP, works because it interrupts the reinforcing cycle of fears and rituals. It targets the exact mechanism that maintains OCD and has very strong support from research and clinical practice and the DSM framework.
For our personality theory section, I focused on the Big Five personality trait model, which is the most used trait theory in psychology. Research and the textbook show that certain personality traits can increase vulnerability to OCD and shape the symptoms that appear. People with OCD often score high in neuroticism, which means they experience more anxiety and distress from intrusive thoughts. They also tend to be extremely high in conscientiousness, where things like perfectionism, over-responsibility, and a need for control tend to come out. This also contributes to compulsive checking, organizing, or cleaning behaviors. People with OCD tend to have low openness or agreeableness, which tends to express itself in them being very uncomfortable with uncertainty, as well as relying on rigid routines and rules. This low openness also lends itself to a low extroversion score, meaning that they tend to withdraw more into themselves and have problems with interpersonal relationships. Though personality doesn't cause OCD, it helps explain why the disorder looks the way it does, and why some people develop the certain patterns of obsessions and compulsions that they have. For example, personality traits can shape who is more vulnerable to developing OCD, how distressed they are, and how persistent their obsessions may become. It can shape which symptoms people develop. It will also affect which treatments are successful or unsuccessful for them. Some people with OCD, obsessive compulsive disorder, also meet the criteria for OCPD, which is obsessive compulsive personality disorder, which is associated with more severe symptoms, poorer insight, and worse treatment outcomes, sadly. Overall, personality theory helps to explain why OCD varies so much between individuals.
Studies saw that findings indicated that minorities with OCD are undertreated and underserved regarding both psychological and psychiatric services. Strong ethnic identity or cultural background may affect severity of certain symptoms. For instance, research among Asian Americans has shown that stronger ethnic identity predicted more severe contamination obsessions. Cultural or religious frameworks may provide coping strategies or social support that help mitigate distress. For instance, religious community support, rituals perceived as meaningful, or spiritual interpretations may reduce an alienation, but this depends heavily on the context and whether rituals become intertwined with pathological compulsions. Common attribution errors and misperceptions, especially in cross-cultural contexts. Misattributing culturally normative rituals as pathological compulsions is extremely common, assuming that a person's religious washing, prayer, or purity rituals are symptoms of OCD rather than culturally appropriate practices. An article from Psychology Today explains that with the permission of the client, the therapist can reach out to the traditional healer to describe the client's problem and the model for the CBT treatment approach. Attributing OCD symptoms to superstition or spiritual weakness. Some may view symptoms, especially when religious or moral, as evidence of sin, evil, or weak faith, rather than a mental health disorder needing evidence-based treatment. This can discourage individuals from seeking clinical care. Assuming Western or typical OCD symptom patterns, reflecting all OCD. Ignoring that different cultures may have other dominant themes, which can lead to under-recognition or misdiagnosis. Blaming individuals for their symptoms, moral judgments, and shame. This interprets their compulsions, obsessions as personal feelings, as a lack of willpower or moral impurity, instead of a psychiatric disorder influenced by biological, psychological, and cultural factors. This contributes to stigma and self-stigma. Societal attitudes, prejudice, and barriers regarding OCD, especially in minority and cultural communities. Undertreatment and service disparities for ethnic minorities with OCD. Research shows minorities are significantly less likely to receive evidence-based treatment such as therapy and medication compared to non-minorities, even though severity and disability levels may be similar. Higher reliance on informal or traditional care such as clergy, healers, religious or community supporters. Many from minority or culturally traditional backgrounds may prefer help from religious or traditional healers rather than mental health professionals. Stigma, shame, and misunderstanding of OCD in some communities. Mental health illness may be taboo. Symptoms, especially tied to morality or spirituality, may be judged as moral or spiritual failings rather than a treatable disorder, making individuals reluctant to disclose or seek help. Mistrust or discomfort with mental health services. Due to cultural differences, language barriers, and lack of culturally competent clinicians, and past experience of bias or discrimination, many from minority ethnic groups may avoid or delay formal treatment. Need for culturally informed outreach and treatment adaptation. Because of differences in symptom expression and help-seeking behavior across cultures, there is a strong call for the culturally sensitive assessment, therapy, and public education to reduce disparities.
In conclusion, OCD is highly treatable. With proper treatment plans, symptoms can improve up to 60 to 70%. These symptoms can be chronic, but they do become manageable, with better outcomes when treatments start early and when they're consistent. Some things that people with OCD might want to integrate into their everyday lives, as recommended by the APA, are mindfulness and acceptance skills. These skills reduce emotional reactivity and help individuals observe intrusive thoughts without engaging in their compulsions. Regular exercise, healthy sleep routines, and reduced stimulants, aka coffee, also helps lower anxiety and improve their daily functioning. Additionally, talking to your friends and family about your symptoms and struggles always helps. There are also plenty of support groups where people can feel free to talk about their own experiences with OCD. Some of the key things we learned is that ACD is shaped by cognitive patterns, personal traits, and cultural context, making each person's experience with OCD completely unique. Effective treatment requires both evidence-based therapy and cultural competent care. Without these, the treatment will not be as effective. As a society and as psychologists, we must understand OCD holistically. This will reduce stigma and improve support for affected individuals. You see, with appropriate intervention, individuals can lead healthy, meaningful, and productive lives with OCD.